Welcome everybody to the first Repro 360 webinar. Welcome to all our attendees. I believe we actually have some European attendees on for this session. For those from Europe, just bear with us because you will find that there are some information throughout this presentation that has Australian context. Just a bit of housekeeping before I begin. For those that haven't used this platform before, on the right-hand side of your screen, you will see a pane. And in this pane, there should be a section where you can actually ask questions. So I invite you throughout the presentation to ask your questions. And during this time, at the end of the presentation, I'll then be able to hopefully answer most of those questions if time permits. If time doesn't permit, then I will be able to answer everyone's questions and email out to the list of the attendees. So today what I'm presenting to you is the artificial manipulation of bovine reproduction. And this presentation is intended to be a one-on-one or 101 of pharmaceutical hormones and their use in common protocols. So for some people this could be new information, and for other people this could just be a refresher. So at the end of this presentation, hopefully a little pop-up will occur, and in that section there's just a little space that if you would like to hear more information, because we plan on doing a series of these webinars, if you could just put some feedback in there as to what information you would like to hear from us. So moving right along, just an outline of what I'm going to speak about today. We will go through the common treatments, so the common pharmaceuticals and their effect on ovarian function. I will then discuss how we use these treatments. And I would like to make it very clear the difference between estrus and ovulation synchronization. I think sometimes we don't compare these as separate protocols and their uses. And then I'd like to step you through the theory of common ovulation synchronization protocols, and I will do this in a pictorial demonstration. So the common pharmaceutical programs that we use in synchronization programs. So before I commence, I just wanted to review the bovine estrus cycle. Now, although this is probably common knowledge to most here, it's very important to understand the bovine estrus cycle, because without knowing this, it's very difficult to understand and alter synchronization protocols. So just briefly, the cycle goes from ovulation to ovulation. And the point of ovulation, a corpus luteum is formed, of which then it increases circulating progesterone through the luteal phase. But also after ovulation occurs, a new follicular wave emerges. So this is a really important point to remember. Now, throughout the bovine estrus cycle, there's approximately 2 to 4 follicular waves. Most cattle tend to have 3 follicular waves. Now, each of these follicular waves are actually sparked by short increases in FSH concentration. Towards the end of the cycle, the progesterone is removed from the circulation when the uterus secretes prostaglandin. The use of prostaglandin then causes the demise of the CL and removes circulating progesterone, allowing that follicle to grow through. Now, as the dominant follicle increases, it increases in estradiol content, and then following estradiol, you then see a surge in LH. And this surge in LH then causes ovulation, and the cycle starts again. So moving on to the pharmaceutical preparations, the most common pharmaceutical preparation hormone that you will find is prostaglandin F2 alpha. Now in Australia, cloprostenol is the most common analogue that is used. However, in other countries and in Australia, we also have dinoprost. Now, the main function of prostaglandin is that it induces luteolysis of the CL, which then causes a cascade of events such as the growth of the ovulatory follicle, increase in estradiol, and then LH surge, which causes ovulation. But simply, the best thing to remember is that it removes CLs. And what we do know, that it features in all synchronization protocols. Now, this is all common synchronization protocols. I have seen some non-cycling cow programs that don't feature prostaglandin. The second most common hormone that is seen is gonadotrophin releasing hormone, although most people tend to just call this GnRH. Now, GnRH works directly on the hypothalamus. However, just to remind you that synthetic GnRH primarily has LH activity. So some people get a little bit confused that it could have some FSH activity, but for the simple means of remembering it for synchronization purposes, it has LH activity. Now, what we know about the use of GnRH is that it will induce ovulation in an LH responsive follicle. So to have an LH responsive follicle, we're looking at follicles usually greater than 10 millimeters in diameter. What we do know is that greater the diameter of the follicle, we get a greater response. Now, this, of course, doesn't include cystic follicles. If an LH responsive follicle does not exist, then nothing happens. So this is another important thing to remember in synchronization protocols. What we do know is that Bos indicus cattle tend to have a lower response to GnRH than Bos taurus cattle, and we also know that heifers have a lower response than cows. An alternative to the use of GnRH is estradiol benzoate. Estradiol benzoate is a very efficacious product. It has two functions in the fact that it initiates a new follicular wave when progesterone is present. So if you use estradiol and progesterone together, you create a new follicular wave. However, when progesterone isn't in the circulating, it induces ovulation. Now, estradiol benzoate is only effective when used in conjunction with a Q-mate device or other progesterone devices. However, I do acknowledge that in the Australian environment, we do have restricted use in lactating dairy cows, and there is also a ban on this product in the EU, US, and New Zealand markets. So just to reflect on the bovine estrus cycle and how this dual action of estradiol works. So if you think during the luteal phase, when we have an increase as the dominant follicle grows and producing estrogen and progesterone is in the system, you see that there is a suppression of gonadotrophins, which then makes the dominant follicle become atretic, which then initiates a new follicular wave. However, if there is no circulating progesterone, a surge in estradiol concentration will subsequently cause a surge in LH secretion, inducing ovulation. So that's how it works with its dual action. The other product that's commonly used in synchronization programs is progesterone. Now, progesterone is often utilized as an intravaginal progesterone releasing device, such as the Q-mate. Now, the purpose of the Q-mate device or progesterone devices is that it provides a sustained release of progesterone when in situ in the cow. Now, this is so that it mimics the diestrus phase of the estrus cycle, the diestrus phase also known as the luteal phase. As a synchronization treatment, we know that the use of a Q-mate will improve synchronization of ovulation. It can induce cyclicity in anestrus or prepubertal females. And as mentioned before, it has a synergistic effect with estradiol benzoate to suppress gonadotrophins. But simply to remember that Q-mate devices improve synchronization of ovulation and can be used to induce cyclicity. The other hormone that is commonly used in artificial reproduction in cattle is equine chorionic gonadotrophin, or ECG. In cattle, Pregnicol, or ECG, does not synchronize ovulation. In sheep programs, Pregnicol is known to have an effect to help the synchrony of ovulation, but in cattle it does not. So in cattle what we see is a combination of LH and FSH activity. And this activity approximately has a 40-hour half-life, so it has a sustained release. Now the primary action of Pregnicol is to stimulate ovulatory follicle growth. Now if we stimulate follicle growth, we expect to have a larger follicle at the time of ovulation. Now optimal follicle growth will result in optimal CL function. And we do know from some field trials that there is a relationship between larger follicles and higher fertility. When I'm asked to describe the action of Pregnicol or ECG in the field, I simply liken it to follicle fertilizer in the fact that it does improve ovulatory follicle growth, and it is great when there may be a situation where the cow is lacking, hence when you would tend to use fertilizer. So now that I've walked you through each of the steps and each pharmaceutical hormone that we commonly use, the big question is, how do we use them? And this, I've likened this to a bit of a puzzle. How do we put the puzzle together to get the outcome? So as I described at the beginning of my presentation, there are two ways to group synchronization protocols. We have synchronization of estrus and we have synchronization of ovulation. Now, synchronization of estrus is commonly used when you are happy to do estrus detection for artificial insemination or embryo transfer. And in these programs, it is not essential to use inducing agents for ovulation, for example, GnRH or estradiol. And in these programs, the aim is that the cows are ovulating and showing behavioural estrus over approximately 1 to 3 days. For the purposes of the time frame of this presentation, I won't step you through all the estrus synchronization protocols. I'm going to spend more time focusing on synchronization of ovulation. Now, if we synchronize ovulation, we then have the ability to do fixed time AI or fixed time embryo transfer. But in order to do this, we need an ovulation inducing agent such as GnRH or estradiol at the end of the program. I'll explain this later. In these programs, the demonstration of estrus or behavioural heat becomes less important. It is more about that time of ovulation. In these programs, we're aiming that these cows will ovulate within a 12 to 24-hour window. And this gives us a nice tight window to enable fixed time AI or fixed time embryo transfer. So I'll now walk you through ovulation synchronization. So for ovulation synchronization programs, we need to do two things. The first thing is to initiate a new follicular wave. In other words, restart the cycle. And secondly, we need to induce ovulation to have this tight time frame of ovulation. So realistically, then there's no need for estrus detection. So to commence a new follicular wave, we know in the estrus cycle that a new follicular wave occurs when a dominant follicle becomes atretic or after the time of ovulation. So how do we do this? We know that we can use GnRH if we have an LH responsive follicle, i.e. greater than 10 mils. Or, as explained, we can use the combination of estradiol and progesterone together to suppress the gonadotrophins and cause the dominant follicle to become atretic. So to induce ovulation, we must have an LH responsive follicle present. So setting up the new follicular wave makes a very good situation for this. We create a surge in LH secretion, which then induces ovulation, and this then causes luteinization of the thecal and granulosa cells and formation of a functional CL. And the best way to do this is to artificially create a surge in LH through administering GnRH or estradiol benzoate when there is no circulating progesterone. So there are two types of ovulation synchronization protocols: GnRH-based protocols with or without the use of a Q-mate device. And these are called the OvSync and the CoSync programs, or the estradiol and progesterone programs. Acknowledging there's some restricted use of these programs, they're very common in large beef countries such as South America and Australia. There are different types of estradiol, but estradiol benzoate is the most commonly used. And you actually can incorporate some in GnRH as well, which I'll explain. So stepping you through the OvSync program, probably the most common GnRH-based protocol for ovulation synchronization. So assuming on day 0 you administer a GnRH injection and there is a dominant follicle present, you will then cause ovulation. Now, through causing ovulation, this will start a new follicular wave and, of course, produce a corpus luteum. Now, around day 7, you then need to remove any circulating progesterone that is in the system to enable the dominant follicle to grow. The prostaglandin will do this, but this is also the time when you can administer Pregnicol, or ECG, to allow the growth of that dominant follicle. On day 9, once the dominant follicle has time to mature and grow, you can administer GnRH. Again, this is your ovulation-inducing agent. Enabling fixed time. Now, the reason we can fix time is because we know approximately after GnRH injection, there is 30 hours until ovulation. So if we fix time 16 hours after this GnRH injection, we've got the most optimal time for artificial insemination for the best fertility. Now, these programs can be used with or without a progesterone device such as the Q-mate. The other GnRH program is a CoSync program. Now, it essentially is the same as the OvSync program, whereby GnRH induces ovulation, causing a new follicular wave to emerge. Prostaglandin is administered around day 7 to remove the corpus luteum and allow the dominant follicle to grow. However, what you can do is administer GnRH and fixed time at the same time. Acknowledging that we still have a 30-hour window, what this enables us to do is to AI and only have 3 handlings. I do like to think that our semen quality is good, which enables that semen quality to last through to the time of ovulation. And again, we can choose to use a Q-mate device in these programs to improve synchronization and to help in non-cycling cows. So the OvSync and CoSync programs, there are some limitations to these because we know the response to the first GnRH injection is sometimes variable. Non-cycling cows may not respond to the GnRH injection, and the GnRH is typically more expensive than estradiol in Australia. And we also know that Bos indicus cattle and heifers respond not as well. So to improve this response, the best way is to either pre-synchronize, because we know that we get a better result if we have the program starting from day 5 to 12 of the estrus cycle, or we can give a progesterone device. So now I'll move on to the progesterone and estradiol-based programs. In these programs, when we insert the Q-mate device and administer estradiol benzoate, what we see is the dominant follicle becomes atretic. Now, through becoming atretic, this enables a new follicular wave to emerge. At the time of QMate removal, usually day 8, we administer a dose of prostaglandin. Now, the reason we do this is because we're usually unsure whether the cow or heifer has a corpus luteum, and this ensures that we remove all circulating progesterone. And at this time, we can choose to use Pregnicol as follicle fertilizer to improve the dominant follicle growth. 24 hours after the removal of the device, we administer estradiol benzoate. Now, doing this, it actually creates a surge in LH 17 to 20 hours later. This enables us to fix time AI in a very tight window. So just stepping you through these programs, generally we insert the QMate and estradiol benzoate, and at day 8, or we can do it between, day 7 and day 9, we have the option of removing the device. There's little difference in results between day 7 and 9. At this time, we use prostaglandin to remove any corpus luteums. 24 hours, we use estradiol benzoate, and 54 hours after the removal of the progesterone device, we commence fixed time AI. I generally do not recommend AIing before 54 hours. The reason is because we know that majority of the animals actually ovulate between 60 and 72 hours after the QMate is removed. Now, these programs are great for cycling or non-cycling cows. There is no need to pre-synchronize, however, it does require 4 handlings. Now, if you remember back in a previous slide, I mentioned that we can actually combine GnRH with estradiol programs. The reason for this is because, as mentioned before, the GnRH can be given at the time of fixed time AI. And this allows us to have 3 handlings only. So we have the same time of 54 hours later. Now, this program is most commonly used in the southern beef industry in Australia, where we see lactating Bos Taurus cows that tend to respond best to GnRH. Usually, I do not recommend these for Bos Indicus programs. So I'd like to thank you for your time today. I'd just like to highlight that we have a Repro 360 helpline. So for anyone that wishes to have any questions at any time, you're welcome to call us through. We also have a dedicated expert hotline, 360 Expert Australia. And we also have a website which has plenty of resources of repro360.com.au. And I welcome anyone to keep putting any questions they may have through at this point in time. I do have one question here that I will answer. The question has come through regarding back on my comment with prostaglandin, and I mentioned the cloprostanol versus dinoprost. And the question is whether or not there is any difference between the use of these 2 analogues. So there has been found that there is no difference between cloprostanol and dinoprost. Most people tend to use cloprostanol in Australia. It's become more so the matter of norm. It is a different dose. It is a 2 ml dose versus a 5 ml dose, and some people prefer to use the 2 ml dose. But essentially, there is no difference between cloprostanol or dinoprost. Thank you very much. There's no further questions that have been emailed through. So what I will do is I'll ensure that I email these out to the attendees. Thank you very much for your time, and I welcome you to attend further webinars. Thank you very much.